streaming in just a couple of seconds, just an FYI.
Okay.
In just a couple of seconds, just an FYI.
Hey, Adam, you're going to introduce Aaron, right? Who I see just talking.
Yes.
Great. Hey, Aaron.
And Heather has 4 people who she's going to introduce as well.
Okay.
All right, we're at 4:02. Do we got everybody? Hold on, I can't. I'm trying to count the board members here. Okay, hold on one second. I'm just having quick audio issues. One moment. All right. Now can I hear people? Yes. Okay, great. Sorry, I couldn't hear anybody. And I was like, I think I'm talking to myself. Am I on mute? Am I not on mute? What's going on? Okay.
We weren't talking.
Oh, okay. Well, that could be it. That could be it as well. All right. Awesome. All right. Well, let's get this meeting called to order. It is 4:03. Renee, would you like to start with the roll call, please?
Sure. Please say present after your name is called. Representing Adams County on the Board of Health, Julie Mollica,
Present.
Rosanna Reyes,
Present.
and Julie Shells, who I believe is absent tonight.
Yes.
Representing Arapahoe County on the Board of Health, Jan Brainerd,
Present.
Dr. Thomas Faywell,
Present.
and Dr. Kaya Gallagher.
Present.
Tri-County Health Department Leadership, Adam Anderson, Interim Director of Planning and Information Management.
Present. I don't know that I'm interim anymore, though. Just as a note.
Oh, thank you. No one passed that on to me. Michelle Eskenazi, Director of Emergency Preparedness, Response, and Communicable Disease Surveillance.
Present.
Heather Baumgartner, Director of Community Health Promotion.
Present.
Lisa Bolstad, Administrative Assistant.
Present.
Jill Bonchinsky, Director of Nutrition.
Present.
And I'm Renee Brockman, Executive Assistant. Monique Didier, Director of Administration and Finance.
Present.
Dr. John Douglas, Executive Director.
Present.
Maine Furman, Director of Human Resources.
Present.
Penny Grandy, Director of Nursing.
Present.
Brian Halabasek, Director of Environmental Health. And Jennifer Ludwig, Deputy Director.
Present.
Now, Brian is waiting to testify on a bill. He'll be with us shortly.
Okay, thank you. Roll call is complete.
All right, great. Do we have any other introductions that anyone wanted to make quickly before we get going? Michelle?
Yes, I'd just like to introduce Alex Kellogg. She is our COVID-19 Partnerships and Strategies Program Manager, and she's here should there be any questions when John does his brief COVID presentation.
Awesome. All right. And Heather?
Hi, I'd like to welcome Emma Goforth, Jesse Reeder, and Dr. Mara Crozer, who are going to be presenting later on our mental health FIP update. And then also welcome Angelia Baker, our Youth Engagement Supervisor and Community-Based Prevention Coordinator in CHP. She's going to quickly introduce 4 new staff members who have recently joined the division.
Great.
Good
And then-
evening, everyone. I'm Angelia Baker, like Heather mentioned, and I'd like to introduce the Youth Engagement Team, or we're better known as the YES team, just a short acronym. And I have Michaela Valentine on our team, Shayna Shaw, Libby Harrington, and Jalea Grace. And I'll let them briefly introduce themselves if this is appropriate time.
Sure, feel free. If you'd like to call on them, maybe one at a time.
Michaela. Let me see. I'm not sure if she's on here. Libby,
Okay.
if you'll go ahead.
Yeah, hi. Apologies for being on my phone. I'm actually with some youth right now doing a running program. But I'm Libby Harrington. I work on the tobacco team and then also in the I-70 corridor out in Adams County as a youth engagement specialist.
Great.
Shayna.
I'm not sure if you can hear me, but I'm going to leave my screen off because I'm driving. But I'm Shayna Shaw. I work with the in the Aurora area with the youth engagement team, and it's a pleasure to be here.
Great. Thank you. And we heard you.
Jalea. Okay, I'm not sure if they're on here. All right, I'm not seeing the other two on here, so I won't
Okay.
hold you any further, but thank you so much for allowing us to briefly introduce ourselves.
Yes, no, thank you so much for being here. Heather, did you have anyone else to introduce?
That's it.
Okay, all right.
Yeah,
and, then,
thanks.
and then Adam, I see your hand.
Yeah, so we have a new lean facilitator and project manager to replace Daniel Barton and Doug Glenn. And her name's Erin Phillips. She's from Denver Health, and she's assisting with developing plans and processes to help with our transition work. Erin, do you want to just say something real quick?
Hi, yes, so as Adam mentioned, my name's Erin Phillips. I come from the Denver Health Lean Academy, where I was a senior facilitator. Now I'm working with Tri-County to do some process improvement, working with the epidemiology team, and then doing some long-term planning for the transition of activities to the counties.
Great. Awesome. And then Rosanna Reyes.
That was a mistake. I wanted to do a thumbs up, but I realized it was
You
to all
had
the new folks joining us and the new the report.
Awesome.
Do that
So we
a
had
thumbs up.
an emoji error, but that's okay. We got this. Quick question. All right. So as we move forward, thank you all. And thank you everybody for being here, especially new faces. We definitely appreciate people who take out their time out of their day to, join these meetings and work with the Board of Health. We really appreciate it. Our next item on the agenda is approval of the minutes. We have 2 sets of minutes that we have to approve, so we'll take them one at a time. Can I get a motion or a motion for the approval of the March 10th minutes?
So moved.
Second.
All right, thank you. Any discussion? All right, all in favor, please say aye.
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 All right, taking our second one, we have, can I get an motion for the approval of the March 22nd minutes?
Madam Chair, I have a point of order or correction for this
Yep.
set of minutes, March 22nd.
Go ahead.
A correction needs to be made where Julie Schultz from Adams County was present at the start of the meeting. The 2 Julies were transposed.
Okay. Perfect. We will make that note. Can I get a motion to approve the March 22nd minutes?
So
With the amended change? Sorry. Thank you. Do I get a second?
Second.
All right. Thank you. And all in favor, please say aye.
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 All right. Thank you so much. Our next item on the agenda is the unaudited December 2021 year-end financial statements with Monique. Please take it away.
Real quick, Julie, just a quick question. I know
yes, ma'am.
people were in favor of both sets of minutes passing. The second with the correction that Rosanna mentioned,
Yes.
but was anybody opposed?
Oh, was anybody opposed in those minutes? No, no
All
opposed.
right, thank you.
Thank you.
Okay, so our unaudited December 2021 financial statements. Through the end of the year, excuse me, revenues not including the budgeted fund balance use came under budget by 5.3 million, and our expenditures were under budget by 11, bringing us a net income year to date through December at 5.7 million. In December of 2020, the Board of Health adopted the 2021 budget totaling 5.5 million, and in July and October, the board approved the supplemental budget of 11.3 million and 1.9 respectively. So our new revised budget for 2021 was 68.7 million. Revenue through December totaled to 61.3 million, which again was under budget by 5.3 million. And those 2 programs are what the variances consisted of, the majority of the variances. Expenditures totaled 57.6, which was less than budget by 11 million. The major expense variances, again, were pretty much the same. We have our charts for 2021, expense budget versus actual. And overall, our net income year to date through December 2021 was 4.4 million, sorry. The net income year to date includes the planned use of fund balance. So we ended the year with unaudited additional 4.4 million being added to the fund balance. Those are our charts for year to date. And we ended up with our investments having a loss of $29,683. Any questions?
Questions for Monique? Rosanna, I see your hand, but I don't know if that was a layover from the last.
Indeed, it was a layover.
Okay. All right. Any questions or concerns the board has with Monique's presentation? All right, I'm not seeing any or hearing any. So thank you so much for that. We really appreciate it. All right, moving on to our informational items. First up, we have community health assessment results for Arapahoe County.
Hello.
Hi.
I'm a good. How are you?
Good.
I'm a population health epidemiologist. I'm on Adam's team on PIM, and I'm going to share my screen. Please tell me if you do not see this in presentation mode.
I see it, and it is not in presentation mode. So a win.
Oh, it is. It is. Okay. Okay, great. So these are the results of the 2022 Community Health Assessment in Arapahoe County. The full assessment is posted online. So when you get a chance, please take a look. You can just look at tchd.org/chalk. And I just wanted to thank the team. We had a large team, as you can see, from a variety of different divisions. Everyone played an important role and worked really well together. So thank you to everyone who participated. If you've looked at the 2018 CHA, you'll notice that it looks very similar. There's a similar format. Most of the sections are actually the same, with an addition of a COVID-19 specific section. And there's also a couple section specific details. So each section or chapter has this key insights box at the beginning that kind of summarizes, I suppose, an executive summary of that section. So if you didn't want to read the whole chapter, these would be the things we wanted you to take away. And then at the end of that chapter, there's a what our community said. And these bullet points summarize the community engagement work that we did. And I'll talk a little bit more about that too. So I think I've talked to you about this before, but we follow the Colorado Health Planning, Colorado Health Assessment and Planning Process, CHAPS. It requires that that we do a community health assessment every 5 years. It's also on a 5-year cycle per FAB, or the Public Health Accreditation Board. It's an 8-step phase, and it walks a health department through kind of the assessment and planning phase to end up eventually at a FIP, or Public Health Improvement Plan. The CHA is phase 3, and we are handing these over to the counties. So we hope that they will use them and be able to kind of start at phase 4 when they're at that point. Okay, so the community engagement. We did a much more robust process this year than we have done in the past. We worked with community-based organizations. We funded them to do both focus groups as well as survey outreach and one-on-one survey entry. These are the these are the community-based organizations in Arapahoe County that we worked with. I think I've shared this map before too, so you might have seen it. Aurora Economic Opportunity Coalition, Innovative Housing Concepts, and Sheridan Health Services. And they are located in these kind of high priority neighborhoods. These neighborhoods were determined using the CDC Social Vulnerability Index, which maps, kind of takes 17 different American Community Survey indicators, and using this index marks the different census tracts as far as low to higher vulnerability. And the groups that we worked with were all located in higher vulnerability areas. In addition to the community engagement with community members, we also did surveys. You all probably took one of them. So we had one for elected officials and government leaders. We had a partner survey. We surveyed staff. And then we also did an environmental scan and literature review. And then the secondary data analysis, we used over 30 different sources of data. A lot of them are state and national sources. So Census Bureau, Department of Local Affairs, CDOT, CDPHE, of course. You'll see as I go through that the data sources have different cycles. So Healthy Kids Colorado, for example, is done every 2 years. So we don't have the 2021 data yet. Those data are still from 2019. Other data like mortality data, of course, we get more quickly. Okay, so here are the findings. So the community survey, we had almost 1,000 participants, residents take our community survey. Not residents, rather people. 673 of those were residents, which is much higher than we had in 2018. 15% of them responded in Spanish. That's a slightly higher percentage than is the estimated population that speaks Spanish in Arapahoe County, so we were pleased with that. 14 elected officials and leaders, 253 Tri-County staff, and these are staff that serve Arapahoe County residents, and 20 partners. We had over 100 people participate in the focus groups, which was great. Again, these were facilitated by the CBOs that we funded. There were 8 focus groups total, and we conducted them, or rather they were conducted in English and Spanish. There were 2 questions that were on all of the surveys and asked in focus groups. One of those was, what are the 3 most important characteristics of a happy, healthy, thriving community? These are the top 10 responses. The top 5, you can see social factors, access to care, safety, health behaviors, and economic security. And then slightly different, what are the 3 most important health problems in your community? Again, these are the top 10: access to care, safety, social factors, food, and economic security. And these categories end up becoming kind of the section chapters. Okay, so now I'm going to go through the different themes. So social connections and health. We saw this in 2018 too. Social connection kind of rose to the top. I think we noted, especially with the focus groups and surveys, that it was very obvious to residents that social connection and the opposite of that, isolation, was important or was a big deal. And a lot of that happened because of the COVID-19 pandemic. These are some indicators, sorry about that, that look at connection and belonging among high school students. Again, these are from 2019. These are Healthy Kids Colorado data. Starting from left to right, we're looking at bullying. So this is bullying on school property. Arapahoe County responses here in the burgundy color and the peach color are Colorado. 15% of students reported being bullied on school property. That's also actually higher than electronic bullying, which was only 13%. So I think we often, talk about social media and worry about that, but according to this survey anyway, more of the bullying was happening in person on school property. And then we look at kind of teasing is the way they phrase it. So we see teasing based on race or ethnicity. And then the middle kind of section here is teasing based on physical appearance. And 40% report being teased for race or ethnicity, and 60% if they were teased, it was because of their physical appearance. Then the next 2 are looking more at like social support, connection, having a trusted adult. We know that having a trusted adult is really important for youth. And you see about 80%, 70% in this latter one report having some sort of trusted adult that they could ask for either a personal problem or a serious problem. I think something to keep in mind here is that means that 1 in 5 or even more than 1 in 5 don't have that, which is pretty large when you're talking about a group of high school students. Okay, economic security. So I think, obviously income, economic security is a key social determinant of health. We talk about it a lot. It's important. Opportunities that lead to wealth are not equitably distributed in our communities. Again, the pandemic has impacted us all. Job loss, raising prices, housing, I'll talk more about that later. Here, this graph looks at people in poverty by race as a percentage of two different things. So the burgundy bars look at percent in poverty of the total population of that same racial group. And then the peach colors look at of the total population. So for example, if we're looking at white alone, while 60% of the total population, 60% of those are white. If you look at just white non-Hispanic folks, only 6% of them are in poverty. So that's kind of a different way of looking at it. I think we tend to look at the whole population. So looking at this next one here, Black or African American, non-Hispanic, 13% of Black or African American folks among Black or African American people are in poverty, whereas they make up 21% of the total population in poverty. Okay, and then these two look at self-reported health status by income. And on the left, we're looking at general health status. And on the right, we're looking at mental health distress, which is 14 or more of the past 30 days. So it's about 2 weeks of having pretty poor mental health. The different household incomes here are less than 25,000, 25 to 49,000, and 50,000 or above. And just keep in mind that 50,000 or above for a household income is still not very high. So when we're looking at general health status, you can see, the burgundy bars here are the very good. The yellow bars are good, and then the blue bars are fair or poor. So those who make 50,000 or above or have that as their household incomes are much more likely to say that they have very good or excellent health status. And then, you kind of see the trend moving the other way. When we look at self-reported mental health, the graph on the right, it's a little less dramatic, I would say, but we still see that among people with higher household incomes, fewer of them report mental health distress. Okay, housing. So I think it's no surprise the cost of housing is outpacing wages in Arapahoe County. I'm not going to read all of the comments on the left, but let me talk about this graph. So this looks at trends in median home value and annual median household income. Arapahoe County is in this burgundy color. Again, the peach color is Colorado. The top dotted lines are this median home value. So you can see how it's changed over time. This is 2012 to 2019. The peach are the bottom lines, the solid lines are the median annual household income. And what we see from 2012 to 2019 in Arapahoe County is that while home value went up 78%, annual median household income only went up, I believe it was 37%. On the left, we're looking at monthly renter and owner housing costs exceeding 30% of the household income. 30% is the standard set by the Housing Act of 1937, I believe, with the year, where you don't want to spend more than 30% on your housing so that you leave enough income for your other necessary expenses. In Arapahoe County, 53% of folks are spending more than 30% of their household income on rent. So that's renters. Among owners, 27% are spending more than 30% of their household income on rent. On their housing costs. This is a slightly different way of looking at it. So here we're looking at percent change in income between 2014 and 2019 compared to percent change in rent. So again, rent, housing costs are going up faster than income is. Okay, health and education. So education is important for health. I'm sure you all know for many reasons. Not only does it impact health literacy, one's confidence in advocating for themselves, one's belief that they can make changes, so kind of the self-efficacy. It also, of course, impacts your ability to get a higher paying job and the chances that you'll have employer-sponsored health insurance. So here we're looking at self-reported general health status by educational attainment. This is that same indicator we looked at before by household income. And we see that, that the highest percentage of folks who say they have very good or excellent health are people with a college degree or higher. Okay, health and food. So we saw increases in food insecurity in Arapahoe County in 2020. This is looking at 2018 to 2020. You see it went down a little bit in 2019 and then up again in 2020. In 2020, about 16, almost 17% of children in Arapahoe County were estimated to be food insecure. That's pretty large. In a survey conducted by WIC across Colorado, specifically asking about the COVID-19 pandemic, 63% of WIC clients said that they experience household food insecurity. Food insecurity isn't just happening among families and children. While we do see kind of higher percentage of reported food insecurity among high school students here, it's about 1 in 5 in 2019. Almost 1 in 10, so 8% of pregnant women reported food insecurity and 6% of adults 65 and over. And then this map here looks at food deserts. And here it's defined as either you're low income or you have low access to a nearby food retailer. These are by census tracts, and you can see they kind of surround the Denver area. So we have Sheridan, Englewood, parts of Littleton, and then Aurora. Okay, health and safety. I didn't do much here for this summary. I just wanted to note that fatal car crashes did go up in 2020, despite the fact that people were driving less. So we see kind of a steady incline here, despite this slight dip in 2019. Fall hospitalizations continue to rise as well. And in between 2019 and 2020, we saw burglary, auto theft, and arson increase. Not above what might be expected, but still it was an annual increase. Health and the environment. This year we talked a little bit more directly, I would say, about climate change than we have in the past. I think it was a welcome change. We note that climate change poses a significant threat to the health and safety of our residents. This graph here looks at number of kind of high heat days or days over 95. You can see there's a steady positive increase. On the flip side of that, on the left here, we have percentage of days with good air quality. So that has kind of, the opposite trend. And then one thing to note, means of transportation to work. We saw an increase in the work from home, this blue piece of pie here. So more people were working from home in 2020, which of course we expected. But the majority of people are still taking a car, truck, or van and driving by themselves. Okay, health behaviors and outcomes. This is another one I won't talk too much about. I think some things to note is that obesity among adults has stayed fairly consistent since 2016, but it remains high. So 61% of adults in Arapahoe County are either overweight or obese, and we've stayed fairly steadily at that number. This chart looks at percentage of adults with heart disease risk factors, looking at high cholesterol in the burgundy, high blood pressure in the yellow, and the dark blue is diabetes. And you can see that high cholesterol is the most common risk factor and slightly higher than we see in Colorado. In fact, all of them are slightly higher in Arapahoe County than in Colorado. Mental health. So I'll go through this quickly because I know they're presenting after this. So things to note, nearly 1 in 4 Arapahoe residents reported they were in poor mental health in 2021. Here we see those numbers. These data come from the Colorado Health Access Survey, which is conducted by the Colorado Health Institute. And it's considering poor mental health to be 8 or more of the past month compared to the mental health distress BRFIS measure, which is 14. So here we see it went down, it's slowly increasing. And then between 2019 and 2021, it really increased, likely due to the pandemic. Okay, on the left here, we're looking at mental health distress or suicidal ideation among high school students. So again, these are the Healthy Kids data from 2019. We sometimes call this like the mental health or suicide cascade. Arapahoe County is in the burgundy, Colorado's in the peach. On the far left here, we see that about a third of all high school students in Arapahoe County reported this mental health distress or 2 or more weeks of the past month. So that's, I think higher than we would want. Next, we're looking at percentage of students who seriously considered suicide during the past year, almost 1 in 5, 17%. Over 1 in 10, 13% made a plan about how they would attempt suicide, and 8% actually report attempting. I think it's worth noting that these percentages are probably underestimating the true numbers. And then on the right here, we're looking at self-reported mental health. Self-reported poor mental health. So this is the mental health distress, 14 or more of the past 30 days by different factors, race and ethnicity, and gender and sexual orientation. And we see that they differ by group. So the highest, the group with the most people reporting poor mental health or mental health distress are American Indian, Alaska Native. And then when we're looking at the gender sexual orientation, 40% of bisexual people are reporting mental health distress compared to only 16% of heterosexual folks. And I think, something to keep in mind here is the context. So it's likely cultural, social, different pressures, not something intrinsic to the people themselves. So the environments and the context all matter. Okay, substance use. So alcohol is the most commonly used substance among teens and adults in Colorado and Arapahoe County. Here we're looking at marijuana, current, which is past 30-day marijuana use, adults and high school students. They're fairly similar. We see about a quarter of high school students report current marijuana use, and a fifth, 1 in 5, adults in Arapahoe County are reporting current marijuana use. Also, we're looking at binge drinking. So we didn't see a huge increase in binge drinking in 2020. It did go down among adults between 2019 and 2020. We don't yet have, again, the youth report of binge drinking. There was an increase, however, between 2017 and 2019. And then on the right here, we're looking at age-adjusted death rates for prescription opioids, heroin, and fentanyl. Heroin has been going down since 2018, but you can see there has been an increase in both prescription opioids and fentanyl, and a fairly dramatic increase between 2019 and 2020. Okay, sexual and reproductive health. So we saw decreases in teen pregnancies. Those continue to go down, mostly thanks to the great work of the sexual and reproductive health programs and the Colorado Family Planning Initiative. We saw decreases in gonorrhea, just a slight decrease, but we have seen increases in chlamydia as well as syphilis. And syphilis is the graph that's here on the right. You can see in both Arapahoe County and Colorado, it's gone up fairly dramatically since 2017. And then just another thing to note is that while teen pregnancies are going down, there's still a third of all pregnancies in Arapahoe County which are unintended. Okay, access to care. So this was brought up again and again as a key to health and also a problem in our communities. Cost remains the primary reason why people are going without care. So this graph here looks at percentage of people unable to attain certain types of care due to cost. Again, Arapahoe's in the burgundy, Colorado's in the peach. We see 10% of people didn't fill a prescription because of cost, didn't get general doctor care, 13% didn't get specialty care, dental care, and then just in general had problems paying their bills. We did see, I think I included, I did. So we saw a dramatic increase in people getting telehealth services during COVID. Not so much in Arapahoe County, but in Colorado, but definitely an increase in the county as well. So people using kind of different, different health-seeking behaviors during COVID. And then here on the right, we're looking at people who needed but didn't get mental health care. These data are from 2021, so they are more recent. In Arapahoe County, 12% of folks are saying that they needed mental health care but didn't get it. And then in Colorado, that's number is slightly higher at 14%. Okay, so that was fast. I'm going to skip through this. These are just the next phases. Again, because we will not be continuing into those phases, we're hoping that the county will find this information useful and continue through to their public health improvement plan. I will stop sharing. I don't know if I have time to answer questions, but I'm happy to do that.
Yeah, it looks like we have a couple questions. So let's go through and get those going. So Gian, go ahead, jump on.
Hi, thank you. Thanks, Callie. That was a great presentation. I don't know if you recall this, but I was just curious. I've always been focused on kids and their mental health and physical health. When you mentioned 1 in 5 kids did not have a trusted adult, it seems to me that that might have improved from recent surveys, or am I just thinking about it wrong?
I think I have that open.
That's one little.
Let me see if I can tell you. I do know they changed the question fairly recently. So it had asked, like, do you have a trusted person?
Yes,
and
that's what I was referring to.
It went down because you could include like a peer in that.
I'm sorry, include what?
Like a peer.
Oh,
like,
okay.
You know, a schoolmate or something.
Yeah.
So it's gone down since they changed the question, but let me see if I can find it here.
It seemed to me, but again, you folks do this daily and I don't remember all of this.
Yeah.
I'm just curious if it might have improved that more people are finding trusted adults. It would be great considering everybody right now is all stressed out.
I know. I want to say that it didn't. I can't find it while I talk. I'll put it in the chat later if that's okay. I'll look it up and let
that works
you know.
too.
Okay.
Yeah.
Any other questions, Jan?
Nope.
You good? Okay. All right, Kaya, jump in.
Yeah, thanks, Callie. I just wanted to congratulate you and your team for just the array of data sources that you used and the community response that you got. I mean, really terrific work. My question relates to the concept of safety, because I noticed in the surveys it came out to be a very high important priority. But then when you shared the data about safety, it included car crashes, falls, and crime. And I'm just wondering, since safety is such a broad category, but it's so important, do you have some sense of really what the main concern was, or more importantly, how you're going to respond to that?
Yeah, so as far as safety, we heard everything from things around like your neighborhood safety. I think people are seeing more homeless people, which sometimes they responded as feeling less safe. Crime in the neighborhood came up. So the safety section is actually fairly large, and I just kind of picked one indicator to share with you. When you look through, I would look at both safety and environment, which includes the built environment piece. We haven't talked, the what we would do phase would come next. Unfortunately, I don't think we're going to be able to go through that process. But my hope would be that we could, that the county will of course share some of the data that we have, and that they will use that to come up with different strategies, because there are lots of different issues under safety.
Oh, thank you.
Great. Thank you so much. Tom?
Nice presentation. There are some sobering facts that were presented. This is more of a comment than a question, Callie. It would be interesting if these statistics in each category were somehow presented to the commissioners in each of the 3 counties. If all 3 counties use the same CHAPS categories for their future community surveys, it's going to be interesting to see how much improvement will be realized when each county forms their own health department where there'll be less money and less resources and less services, but we're going to improve all these categories. It's going to be very interesting. Thank you.
Thank you, Dr. Faywa.
Go ahead, John.
Oh, you're calling me. I just wanted to thank Callie and the team. It was, as you can tell, it took more than a village. It was like a city of people working on this. And maybe picking up on Dr. Faywell's comments, I really hope these reports land on fertile soil, certainly within these counties. I think it's very unlikely the counties will have capacity to do these sort of in-depth assessments in the near future. And I think there's a huge amount of rich information from their residents. It's almost certain that even if Tri-County were to continue, Kaya, we would not have been able to address everything that got identified here. But it does create, I think, a baseline for understanding what the community cares about and what the data are that support it, that can let whatever health department's involved, or again, our two new health departments, think about how they can work with their community partners on these really, I think, highly validated problem areas. So thank you, Callie, and others.
Yes, thank you so much for that presentation. It was very helpful.
Thank you.
And it just leads to so many more questions, which these typically do. So it's kind of their point. But yeah, fantastic presentation. Any other questions for Kelly and her team? All right, I'm not seeing any. Thank you so much again for joining us this evening. We are going to move on to our next item, which is the Public Health Improvement Plan Progress Update, Mental Health. Who's going to be kicking this one off for us? Emma.
Yes, I will. Let's get to our slideshow view here. And I'll be joined by a couple of my colleagues. So we're very happy to be able to come back to this group to speak about our Public Health Improvement Plan mental health priority. I want to just give a quick shout out to the team that has really contributed heavily to this area. Also want to give a big thank you to Dr. Mara Proser, who was a co-lead for this priority area for quite some time. And also just a big welcome to Melissa Smith, who has stepped into that co-lead role to support the work group in these efforts. And we have a robust team of members from across the division that have helped us through the years on this priority area. Just as a reminder, our goals for this priority area are to promote mental health and wellness, to prevent and decrease suicide attempts and deaths, and to decrease drug overdose deaths. So large, lofty goals, but all related to behavioral health and suicide prevention. The projects that we initially identified in this priority area have evolved, which is appropriate given how this area really changes and evolves. But the current project areas that we focus on are really highlighted by our work with our partners in implementing the mental health and suicide prevention frameworks. We have a number of activities and projects really focused on data, as well as engaging the community with this work. We have some efforts focused on restorative justice, suicide prevention, and overdose prevention. And I wanted to just make a quick note that this priority area, it really goes hand in hand with our access to care priority area. So there's sort of a continuum of the work that we will talk about today here, where we're really looking at the promotion of mental health and wellness and prevention of suicide deaths and overdose deaths. But that in that access to care priority, there's a strong theme of getting folks access to care for behavioral health, including mental health and substance use. So if it feels a little disjointed, I will remind you to think back to Wendy Nading's wonderful presentation back in February that hit on some of those specific access to care efforts. So wanted to just quickly give a recap of some of the primary work that we've been focused on related to our frameworks. And so hopefully you all have seen those a few times and engaged with them. But this is just a quick recap of the ways that we went about really providing structure and format to our mental health and suicide prevention efforts. So going back to 2019, we engaged in some pretty robust data gathering, including engaging an advisory board and vision setting, and then really working with health management associates to conduct a gaps in assets analysis. We talked with a lot of community partners. We really looked to a lot of the data that we just heard about from Callie. We had many other data sources and literature that we reviewed. And from that, and especially from the engagement and input from our partners, we developed frameworks. I wanted to mention, obviously 2020 was a big year, and we're really proud, I think, to say that we were able to continue this work and keep it a priority amidst all of the redirection of staff and attention to COVID. So I was one of the few staff that continued to stay in my mental health work role and not activated in the COVID response efforts. And we were very happy to be able to continue this work. And I think it really enriched the quality of the data that we gathered as well, especially from our community partners, recognizing that this work happened during the pandemic in the early days through many of the social justice and racial unrest events. And so really was germane to the work that came out of it. So in 2021, we spent a lot of time engaging with community and our partners. We shared the frameworks, gathered feedback. We really tried to increase training and awareness among our staff so that as they were thinking about the intersections of work across many of our priority areas, they had some familiarity with the mental health and suicide prevention work. We held town halls, and we also worked on increasing our visibility outward along our website and other outward-facing products. And then really in this year, we've been focused on bringing these frameworks to life. So I'll talk here in just a moment about the community summit that we held in recent weeks, and a little bit more about our next steps. So we were able to host a virtual 2-day mental health and suicide prevention partner summit towards the end of February and early March. We were really pleased with the turnout. We had over 50 community leaders each day, and they represented 32 organizations and sectors from across Adams and Arapahoe counties, and a few other statewide and other county representatives as well. And so, we really intended this summit to be fast-paced and to focus as much as we could on discussion and brainstorming and connecting partners together with the idea that we can have a common agenda across our behavioral health landscape, and having commitment from our partners to really be working in clear and coordinated roles with targeted outcomes and accountability. And this is really responsive to those community needs that we've identified. And so just a few quotes here from the participants that I think really represents the importance of the issues, the engagement that we had from many of the partners, and the depth of the discussions that we had. And I just loved that on one of the days we had several people who just said, can we go back to our breakout groups? So we were having such great discussion, and just a great sign of that engagement. So after the summit, we did a survey, and we found that of the respondents, 90% agree or strongly agree the collective impact in this collective approach and cross-sector approach is essential. We had many people who are interested in joining a steering committee or an action team going forward, and all people who responded wanted to stay in communication about these efforts. So I think it really underscores the timeliness and sort of the importance of the issues. And the quotes on the right here, I think, are really important to pull out because we asked, what do we need next? And what do you need from Tri-County? And so much of what was shared is we need backbone support, we need some structure, we need some direction, and we need some accountability. So really thinking about ways that we can keep people engaged and recognize that we can't go back to our corners and do this work alone, that it has to be cross-sector. We heard quite a lot that it has to be cross-county, that we have partners that are shared across jurisdictions. So to the point that was made earlier by both Dr. Paywell and Dr. Douglas, this is a great example of where we cannot be siloed and we cannot be as effective as we can be if we're not partnering. So we really hope that carries forward with our counties going forward. And so we're really in the process of bringing those interested partners back to the table, creating some action plans, reviewing and refining those measures to hold us accountable to this work, and certainly have sustainability as a top question as we go forward in our agency transition. So from here, I'm going to hand it off to Jessie Reeder, who's with our maternal child health team, to highlight some of the work that's happening in the schools.
Awesome. Thank you so much, Emma. Hi, everyone. My name is Jessie Reeder. I am with our maternal child health team, and I lead our social emotional well-being priority area, supporting the social emotional well-being of families across the life course. And thank you for reviewing the summit, Emma. I know that we had some really good representation from our school partners at the summit as well. And it's just always such a good opportunity for us to really learn and understand how we can really best support their students, their families, and really the entire school community. And so much of our work is really learning from and adjusting to our school partners' needs. If there's anything that we've learned in the last couple of years, it's that, right? And for example, a piece of that, we during our COVID-19 response, we really heard from folks that the mental health of their school communities was a priority and that they needed resources and support in this area. And so in collaboration with our internal school policy and prevention coordinator, we created a webinar series that was modeled after the COVID-19 school support webinars. And since September, we've been able to provide a webinar every other month with community partners as guest speakers who really provide some of those boots on the ground mental health support and services for our school communities. And so this includes the Below the Surface campaign, the I Matter program, and the Colorado Educator Support Program. And really, in general, a lot of our support for school partners looks like working directly with the schools and the district level on their mental health initiatives that are already happening. And this really occurs through collaboration and alignment with existing resources and opportunities. For example, we've collaborated with Cherry Creek School District's Mental Health Task Force, Adams 12's Community Partners Connect group, and we're also working on a planning committee for the Denver Department of Public Health and Environment, planning a You Got This Youth Summit event, which is really a metro-wide committee, planning a youth engagement event around mental health and suicide prevention. And we've really been engaged and involved in recruiting and working with our schools to get involved in that youth summit. In addition, we've participated in a state level school mental health community of practice, and we've really identified some opportunities to enhance messaging and support schools, hearing the same thing from kind of that state level as well as the regional level so that they're getting the same messaging all around them. Truly, the partnerships that we've created with our schools is really important in tackling challenges and applying innovative strategies. For example, with partnerships that were developed through our child fatality review teams, and then working alongside our syndromic surveillance team, we've been piloting data alerts for school district specific syndromic surveillance data for emergency room visits that are related to suicide ideation and attempts. Schools often receive delayed mental health data or no data at all, due to the reliance of families self-reporting this information, and this may not happen due to stigma or other reasons. With these data reports, our school districts are receiving near real-time de-identified demographic data for students who reside in the zip codes that are affiliated with the districts. With this demographic data, our school partners can identify opportunities to provide additional supports to their students based on the information that they're receiving. So we're currently piloting this with 2 school districts. And then lastly, we've really been thinking through and kind of exploring what the role is that we play as a local public health agency in supporting a community after a death by suicide, including our school communities, and really understanding what that post-vention support looks like. As a part of this, we've really focused in on some intentional efforts around what a coordinated response looks like from a local public health agency, thinking through what resources and information we can provide, really just recognizing the opportunity to connect our communities with excellent resources that already exist out there, but taking a more coordinated approach to this and making sure that we're providing those resources and information directly to our partners in the communities. Thank you.
Great, thank you, Jessie. So wanted to highlight just a really fun project that we've been engaged in, and this is in partnership with the Metro Denver Partnership for Health Behavioral Health Work Group. But this is a pilot project that we've been able to engage in, where we partner with community organizations to reduce stigma associated with behavioral health, specifically among the Latinx and African American populations in the Denver metro area. So we've done quite a lot of work in support of the Let's Talk Colorado campaign for a number of years. It's been successful in many ways. However, we have some more recent data and indication that while the Let's Talk Colorado campaign has been effective at reaching some populations, we have been less successful at reaching Latinx and African American groups. And so we really wanted to learn from those experiences and see how we could grow the campaign. And so engaging community organizations, really it's kind of a model based around some of the ambassador work that we've done with COVID vaccinations in the communities, but considering these trusted messengers as a real opportunity to increase capacity for them to address mental health stigma, to promote the anti-stigma messages within the communities that they serve, and to help us gather some structured feedback on our communications materials, the dissemination methods, and about mental health stigma in these communities in particular. And so we are serving as liaison to the organizations that are featured here. And some of these organizations are large and statewide and have pretty broad reach with the populations that they serve. Others are very small and in some cases pretty innovative. So we have Caring and Sharing Transformation Center that's really working very closely in the Northwest section of Aurora. Collectiva is a really interesting group. They're actually focused on art and community engagement through art with the Latinx population, but they've embraced the mental health topic and others as well. So this has been a fun and really exciting project to dig into some of the equity issues that we recognize around mental health stigma and the work that we've done and invested in for quite some time. And let's see, so moving on, Mara.
So I think this got mentioned and introduced last time as well, but we are very excited to be participating through NACHO. It is a mentorship program focused on health equity and overdose prevention. So it's very specific coalitions working on substance overdose prevention, how to better integrate health equity. It did come with a little bit of funding, and we did not even apply for the funding. We just wanted the mentorship, but we're excited to have the funding. It will help us fund some community town hall events. And really our goal is how do we better increase community engagement in helping to plan our work. So we are excited to be planning some events in the fall, or excuse me, not the fall, the spring, to really engage the community in what they're seeing in the community and what they'd like to see and how they would like to get involved. We recognize that one of our shortcomings on TCOP is we really don't have a lot of representation from community and a lot of individuals with lived experience. And so we would like to have more community members involved. We also are working to kind of increase our focus on equity and data usage and data visualization. We do have a great data dashboard that I think just got updated. So thank you to the team who updated it, and really thinking through how can we better display our data in an equitable manner, and then also whether it's breaking it down by race, ethnicity where available, or what is the best way to really visualize those data, as well as thinking through how do we use them, how do we use those data for better planning of ensuring equity in our work, and ensuring, I have this pet peeve around interpretation, making sure things are not misinterpreted that could actually lead to worsening inequities. So we're really excited to be doing that. We're working with Columbus Public Health on that effort, and then some TCOP members as well are involved. And then thank you for moving the slides, Emma. A few other updates we have specific to our youth substance use prevention work. You have now met our new youth engagement team. We are super excited. We have 4 new team members, 2 are full-time and 2 are part-time, really focusing on authentic engagement of young people in our community coalitions. And so they're working under 4 separate grants in 4 different communities. So that's our Communities That Care grant, which is a state grant, the Drug-Free Communities grant, which is a federal grant, the Strategic Prevention Framework Partnerships for Success grant, which is federal, and then our state tobacco prevention and control grant. And so this is really allowing us, again, advancing equity by authentically engaging our community and promoting positive youth development by acknowledging that young people have a lot to bring. They have a lot to bring to the table, and they should get a say in what's happening in their community and what they need in their community. We also, and when I say we, I mean the coalition. The team led a lot of this, but the Aurora Partners for Thriving Youth Coalition, which is funded through our DFC grant, launched Parent University, which is specifically for educating and empowering parents and caregivers, guardians, grandparents, anybody who works with young people on a range of topics about how to how they can better communicate with their young person, how they can understand their young person, what they need to know about. I think there's a few about navigating the school system, navigating the justice system, really helping parents. We found in a community survey that parents just felt they needed more parenting knowledge and resources in that way. So this is a direct response to that request. We are also very excited about a new partnership that would be supporting shared learning around restorative justice among schools as well as justice system partners. One of our team members, Teresa Smith, has been working with, I believe, the city of Englewood, who partners very closely with Englewood schools on restorative justice for young people who are involved in discipline, how to have more restorative practices and not enter kids into the system and not focus just on discipline. And they would like to share what they know, and they would like to learn from others. So they reached out. Part of their conversation with Teresa was really around how can we be a part of some shared learning. So we're very excited to have that focus as restorative justice is one of our big priorities as well. And I believe those are the substance use parts.
Awesome. Thanks, Maura. So I think just in summary, we are thinking about what's happening in the coming months and through transition. And I have to credit Wendy Nading for a lot of this language. We felt that it really applied to this priority as well as the access to care. But we have a fantastic team of people who are really well-informed and well-positioned to work with our community partners to advance this priority area. We're certainly concerned and thinking about stewardship for backbone support role that we provide with many of our community collaborations. We're really thinking about ongoing work as it transitions in terms of our support with various advisory boards and work groups, and really thinking about troubleshooting funding opportunities where we could continue to move forward with this work. And I think I mentioned this a little bit earlier, but just want to underscore this is a top priority for both Adams and Arapahoe counties. It's a priority for our partners. We're hearing loud and clear that our partners want to see this work continued in a collaborative way and expect it to be a priority among the new health departments going forward. And that is the end of our presentation.
All right. Well, thank you so much for that presentation. Wow, there's a lot of work going on in this area. So it's great to get an update. Let's move to questions. Rosanna, I see your hand.
Hi, yeah, I put this in the chat as well. I was wanting to know from Emma and Mara as well. What's going on with AAPI, Asian Americans, Pacific Islanders, women maternal health, and particularly postpartum suicide prevention?
I actually think I can toss that to Jessie Reeder. So she is in a role that is really focused on maternal mental health. And it could be something that we can follow up with in a little bit more detail. But yeah, Jessie, would you like to share a little bit about what we're doing with maternal mortality work?
Yeah, sure.
You muted yourself.
Yeah, mute.
I could have sworn I clicked the button. Thank you. Yeah, happy to pop in on this real quick, and also happy to kind of take this conversation offline a little bit further because I know we're cutting into our time here. But yeah, a lot of the work that we've been doing has been focusing in on this idea of the perinatal continuum of care and really understanding all of the different services and sectors that support a family during that perinatal time span and that time period. What we've been doing around that work specifically has been training, supporting these services and sectors to really embrace their role in supporting families during this time period and understanding that they are the ones to interact and engage with the family, to talk about mental health, to support them in that way, and find the appropriate resources and referrals in that process. Alongside that, we have a family-facing navigation tool called Parents Thrive Colorado, which is a really kind of well-organized resources alongside stories of families in Colorado who have experienced perinatal depression and anxiety, and really allowing that space for families to find that connection to those resources in that space as well. So happy to continue this conversation as well and chat a little bit more about additional work happening there.
Great, thank you so much. Yeah, I mean, there's just so much going on here, and I really appreciate just the variety. I don't know how you do it all. Honestly, your whole team, there's just so much going on, and I'm hoping that this momentum could just keep going through transition because it's such important work. Jan, I see your hand.
Hi, yes, just a question. I think it's probably for Emma, or it could be for Maura, but she mentioned it, some of it. When you go into the schools and you work with them, specifically around mental health, I'm assuming, and maybe I hope so, did the schools have their own programs, sometimes peer-to-peer, when it comes to mental health and suicide? Do they have anything in the schools that is not just organizations coming to help them, but peer-to-peer?
Yeah, I can start, and Jessie, if you want to chime in. Schools are quite varied in the programs and resources that they offer. And so we have done some work to try to map and sort of catalog the various programs and efforts. I would say that across our districts, there are a variety of supports, and those include in staff mental health providers, there are groups, there are suicide prevention programs, but it really varies from district to district, and in some cases from school to school. So a lot of our work has been to, try to just ensure that those resources are clear and available, and that we are able to support some of those with data and other best practices.
Thank you. I can tell you that I really am going to miss working with all of you folks that have all these different committees and learning about it and being a part of it. It's been wonderful. Thank you for all your work.
Yes, and I just wanted to thank Heather very quickly for highlighting the big congratulations to the team on their national recognition for the perinatal continuum of care efforts. Wow. Wow. Thank you so much for all that you do. I really appreciate that. Okay, so we are going to wrap this section up because we do have to move on. But thank you again for this amazing presentation. And thank you again for you and your team for everything that you guys are working on. It's a really important topic for this board that we've established over the past couple of years. And we love hearing about this work. So thank you again. All right, John, I think you're up for a COVID-19 update.
Great, Julie. Can you guys see that? Lisa
see it.
Typically help me, but I can't tell if she's there. I've got unstable internet, so we'll just try it. I want to thank the mental health team. I could not agree with Julie more. And honestly, I think, I talked about the Arapahoe community health assessment, which I really think is great. But I think this mental health work that's been going on in our communities longer than Tri-County is designated as a FIP priority, but we certainly have had it as a FIP priority since 2014, is really a very bright torch to be passing to our colleagues in the new health departments. And I know that our partners, as Emma so poignantly outlined, are really ready for that work to go on. So Emma, we got 9 more months to make it rock and roll. And then some of you will be rocking and rolling in our new Adams and Arapahoe health departments, but just again, kudos for the fantastic work. So I sent the board a slide set last night, and because we are short on time, I'm going to kind of go through this faster. I've got an abbreviated slide set that I will review, and I really just want to talk about 3 topics: trends, vaccines, and a modeling update that I just saw yesterday that is not like, oh, there's terrible things around the corner, but it does sort of give me a little bit of pause to think about what could happen if the right sort of variants did emerge. So I think you've been all, following the news. The left is our county trend lines, our 3 counties, Adams, Arapahoe, and Douglas. The right is the state. And the story has been that despite the fact that BA2 is really now the variant of the land, our case rates have remained very low. Now they've inched up a little bit, around 10% or so in the last week, but you can see that we're starting that 10% increase from a very low baseline, which means they're still really low. Now, one caveat that I think you're probably all aware of, but it's worth calling it out, is we think case rate ascertainment is likely to be more and more of an underestimate as we go forward, because more and more people who are going to test positive are going to be doing it at home, and those tests aren't getting recorded. So the trends are important. The absolute magnitudes, we're going to have to be a little more careful about. This is the BA2 story. The left is Colorado. The yellow is BA2. As you can see, the turquoise that was BA1 is now being overtaken. It's about 80% or so in Colorado, estimated by the state health department at this point, BA2. You can see this upper right corner, the CDC's got slightly higher percentages for national stats. And then that stuff in the bottom right or regional estimations, and you can see region 8 where we live is about what the Colorado estimate is, about 75%. A reminder, BA2, closely related to BA1, appears to be about 20 to 30% more contagious, appears to be no more virulent, illness is no more severe as best we can tell so far, and appears to be as well covered by prior immunity from vaccines and maybe from BA1 as we've seen before. So it's here, the Northeast is seeing a particularly big hit on that. Rachel Hurley, he thinks that the next 2 weeks will be our story. We're not really seeing much of an increase now, but if we are going to see an increase, that's the time frame that we might see that. And the more severe metric, of course, the one we've focused on really throughout the pandemic, but I think are now more important than ever, hospitalizations remain not only low, but they're actually still declining, both in the tri-county, 3-county jurisdictions as well as statewide. And what I've put in the bottom there is what I've shown you before, which is the CDC's new community level metrics. These are the metrics the CDC uses to say, when you get into medium or high, there may be some more precautions you need to take, maybe even at the high level, universal wearing of masks in public places as a recommendation, not as a public health mandate. What the red arrow shows you is where that 2.84 cases falls if we were using that in, or rather, if you applied the CDC metrics to Colorado, showing you just how far below that CDC recommends masking indoor for everybody kind of level that we actually are. Vaccines, topic 2. 2 things to note here. Number 1 is that I want to thank our team, Adam and colleagues, for updating our website. We are now showing you overall vaccination, completed vaccination rates in all persons eligible for vaccine. So we were showing you 12 plus. Now we're showing you 5 plus. And those percentages are therefore going to look a little lower because, as you see on the right side of the slide where we're looking at the age group breakdown, no surprise, the younger age groups, particularly the 5 to 11, but also still really our 12 to 15, 16 to 17-year-olds, and really even our 18 to 29-year-olds still have rates lower than folks that are older, which is really directly proportional to the severity that folks can experience. So while folks can experience serious outcomes at every age, I think the population really is acting in accordance with the science, at least in terms of those who've actually decided to take up a vaccine. Note that the booster rates are progressively getting better, but there's still the glass in Adams County, for example, is 54% full. We'd like to see that get more full. These are rates of a single booster, and tracking on who needs a booster and who's gotten a booster is going to get more challenging as more boosters get recommended. And as you're aware, CDC last month put out one of its, frankly, I think some might honestly say lukewarm recommendations about a 4th dose or a second booster, saying folks 50 and above, especially those 65 and above or those under 50 with immunocompromising conditions, should think about or might benefit from a booster. That's a lot less strong language than we certainly use with the primary series or with the first booster. As a witness, I got my 4th dose, my second booster. I looked at the data. I thought it was probably good enough. And the slide set I sent you last night with a clipping from an Israeli study published in the New England Journal of Medicine. I think what we can say is that the early benefit of a 4th dose is very strong. The question is duration. How long does it last? And how do you time it? And, if you're as old as me, and maybe as you've been as fooled as many times by trying to guess what's going to happen, I decided it was like the stock market. I couldn't time it. So, and that is what I'm personally recommending, but the CDC recommendations, again, are a little less ironclad. These are data I haven't shown you before. We've tried to give you information about how we're doing in terms of vaccine uptake by race, ethnicity. What I'm showing you this time is that while our rates still lag in our populations of color, or I'm showing you Hispanic and Black populations here, I was actually pleased to see finally the state give me some data by county, because I couldn't tell how we were doing in our two counties was an outlier or whether or not we were experiencing a statewide problem, which I think we really are. And what we see in this analysis of the 10 largest counties in the state is that the highest Hispanic vaccination rates are in Denver, with Adams second and Arapahoe third. Denver 65.6 and Adams is 59.1. Among African American or Black residents, again, rates are lower. Again, Denver has the highest rate. I didn't put a red line around that because we've been focusing less on African Americans, but I'll just point out that Arapahoe is second of the 10 counties and Adams is third of the 10 counties. So mixed message, if you will. CDPHE did look into a Kaiser Family Foundation report that came out about 2 months ago. I learned about it, by the way, from Ulisa Soto, who's depicted in that little clip in the right. She's an unbelievably fantastic community partner that Alex Kellogg and her team have started to work with. And Ulisa, who I got introduced by Mayor Kaufman, is really rocking and rolling and making things happen. She pointed out the Kaiser report that indicated that Colorado had the second worst Hispanic vaccination rates in the country. CDPHE data people looked into that actually at our request because we were so shocked by that. And it turns out the data in each state are collected differently enough that while we certainly have disparities here, and these are ones that Alex and team are still working on, state to state comparisons end up being pretty rocky. And one of the things we've asked CDPHE to do is to try to work with the state to see if we can even that out and get better apple to apple comparisons. Let me say that Alex's team has continued working on their strategy to set prioritized goals for the team, particularly working on equity related efforts. I'll just quickly summarize the slide since it was in the packet I sent out to you last night. Key things I want to mention are that some of our larger vaccination and testing sites in the community are beginning to close down because CDPHE is not seeing as much uptake and is deeming it simply cost inefficient to keep them open. And I know Alex and as well as Chris Houck, who's sort of heading up our access to testing effort, is following this very closely to determine whether or not when places close, we're going to have any equity shortfalls. Are places going to close in neighborhoods that have been more better able to serve residents that may be falling behind in terms of vaccination? So let me just flag that as an issue that we're going to be monitoring, because while I'm pleased that the ground is being made up, albeit not completely in our disparities, I'd hate to see it undermined by some of these large sites having to close down. Real quickly, modeling report the state provided to us yesterday. Key messages on the left: prevalence much lower than it's been in the past, 1 in 387 currently infected. The team does estimate the obvious that immunity is going to slowly decline in Colorado. BA2 is the variant of the day right now, more transmissible, similar in terms of other things. It could cause an increase in hospitalizations, but they're going to be well below the peaks that we've seen in the past. The real challenge is going to be future variants and what they may do to caseload as well as hospital demands. The right part of the slide, and now highlighted in red, shows you key modeling updates. And I want to really particularly emphasize the increasing update of the use of highly effective treatments. Paxlovid, which when we talked in January, we barely had any of it. 1% of folks were able to access it. That had gone up to 5% by February. It's up to 10% by March. And those treated with Paxlovid are twice as likely to be hospitalized. So while we don't have a perfect allocation system, and we think there are probably still plenty of people who could benefit from it that aren't getting it, we do think it's beginning to make an impact. So let me quickly wrap up by showing you sort of the modeling curves. These are two curves side by side of looking at what we might expect in terms of hospitalizations from BA2 over the next 3 months, depending on how much more infectious it is than BA1. The yellow line is probably the best estimate, 1.3 times more infectious. If it's 1.5 or 1.8 in green and red respectively, you can see we get more hospitalizations, but much, much lower than what we experienced in the fall or in the winter. And even if you have relaxing transmission control all the places, healthcare facilities, public transportation that are requiring masks, for example, decide to get rid of those, or the feds in their mask mandate, we still don't see anything in excess of what we saw before. Now, that's still plenty of folks getting sick, but it's not nearly as bad as what we'd seen before. Now, what if we have a more severe type of variant? And the team modeled two different kinds of variants, one with high infectiousness, even more so than BA1 and 2, 1.5 times more, but low immune escape, which is a fancy term meaning the vaccine works pretty well, and your prior Omicron or Delta infection immunity probably works pretty well. Versus variant B, same degree of infectiousness as BA2, not more transmissible, but now the vaccine doesn't work as well. Now we have what's called high immune escape. And just to quickly shift to the bottom line, more infectious, but not very, are still well covered by existing immunity. We see more hospitalizations with that orange line in the middle being a variant that's got the same severity as Omicron, but we're not seeing things go up higher than we saw in the winter. Variant B, on the other hand, hypothetical variant B, if you look at that orange line again, no more difference in severity. Now we begin to see things really get much worse. So when we think about planning for the future, it's that latter scenario. I mean, any variant that's more contagious, more severe, or likely to escape immunity would be a problem, but it's that last one that, as I sort of think about planning for the future, is the one I would be most concerned about. Key messages from this is, again, that high immune escape system is going to increase our need for treatment as well as hospitalizations, but even a highly infectious one on its own may increase cases and therefore need for surge testing capacity and treatment. And so when I look ahead, and this is a slide I've been ending up all my presentations with, but I've highlighted the new stuff in red. We got to be attentive to new variants. That's not really new, but we're going to have to not get too complacent. We're going to have to be paying lots of attention to maintaining access to highly effective treatment as our supply increases. As our public testing and vaccination sites begin to downsize, we're going to need to be paying particular attention to how we can surge if we need to. And I think how we pivot to surge capacities probably one of our biggest challenges. And then frankly, more data are coming in with each passing month. I mentioned last time new data showing mask benefits. I suspect we'll be harvesting more information, and those harvests may affect how we think about prevention going forward. So let me stop now sharing, Julie, and happy to take any quick questions.
Sure. Yeah. All right. Questions for John. It was a quick presentation, but lots of great information in there. I'm not seeing any hands. So yeah, John, you're off the hook. Thank you so much for that update. All right, guys. So let's move on here. The next thing we have on our agenda is the executive director's report, which, we read ahead of time. Are there any questions or comments that Board of Health members would like to highlight about the report? Kaya?
Yeah, I just wanted to ask about the Suncor situation. It just seems like there's some ongoing conversation. I just wondered what the timing might be for some resolution of the EPA concerns and CDPHE response and the recommended improvements and where things stand and where it's going, I guess.
Brian, you're back. You want to take that one?
Great question. Kate did note, because we had the same question. Kate noted in there that the EPA had all those recommendations. They had a couple of modifications, which we felt was pretty unusual for EPA to do that. So the state has 90 days to respond to those recommendations, and I think there are two very specific issues that they had, and so they can respond to that, or they have to respond to that within 90 days. So I guess we'll see in a few months what that is, and if there's any other information like that Kate might have I can certainly pass that along, but that's kind of where it stands unless there's more specific questions there.
Okay. Any other questions or comments regarding the executive director's report? Not seeing any. The only comment that I had quickly was just a recognition for National Public Health Week, which happened last week, I believe. So a huge thank you again to our Tri-County Health Department staff and their amazing work. And I hope it looks like you guys had a lot of events going on, which is fantastic. And then a quick shout out to those staff who had presented at national and state conferences. That's always a great thing to highlight the amazing work that Tri-County Health Department does and the amazing staff that we have to work with. So thank you for that. All right, other items, setting the agenda for May 12th. Do we have any Board of Health member that is dying to talk about a specific topic in May 12th? We could talk now, or if not, feel free to ping me and Kaya. Roseanne, I see your hand. Go ahead.
Hi. Yes, I just would like another update regarding the air quality and what Brian was speaking to.
Oh, the
Only
Suncor
quite
one?
90 days though. Let me think. If there's any update, I'd like to hear from.
Okay, great.
Katie.
Yep, we
Great.
can definitely bring that back.
Yes, because it's something that, that's on the mining community, at least in Adams County.
All right, Kaya,
Great.
with a virtual and a real hand. Let's go ahead and go.
Thanks. I just wanted to point out to the Board of Health that we were going to ask Dr. Douglas to do the quarterly review, but we postponed that, and that we'll be doing that at the next meeting. And prior to that, we'll be sending out some updated information.
Great. Yep. Thank you for that update. All right. Final remarks, closing remarks from any Board of Health member? And if not, then go ahead.
Thank you, Emma, for thank you, Emma, for all your excellent work and your presentation, as well as Mara.
Yes, the whole mental health team. Very great
team.
presentation. Yes, thank you so much. All right, so we are going to now move into executive session. So let's see here. Randy, can you state the purpose of our executive session and the legal terms that we need to do as we do that moving forward?
Yes. Hello, can you hear me?
Yeah,
Hi,
or Sid,
Sheila?
sorry. I didn't see Sid on my screen. You weren't
All
in
right.
one of my cubes, so go ahead.
Well, good afternoon, Madam Chair and board members. Yes, we are requesting that we move into executive session pursuant to Colorado Revised Statute, Section 24-6-402, parentheses 4 into parentheses B, close parentheses. And the purpose is, of course, so that we can give legal advice to the Board of Health regarding matters relating to dissolution and bylaws and insurance, all kinds of legal matters in that relationship. So we're going to request that there be no recording of the minutes of this meeting.
All right, thank you. And can I have a motion to move into executive session, please?
So moved.
So moved.
And a second, perfect. All in favor, please say aye.
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 Anyone opposed? All right, Renee, can you move us into executive session, please?
Absolutely. It's going to just take a couple of minutes. I need to ask anybody who is not John, Jennifer, or with the Board of Health to go ahead and leave the meeting at this time. This includes individuals who are in the audience. If you registered for this meeting prior to 4:30 p.m. today, I will go ahead and send an email to you letting you know when it's okay to join the meeting. I am going to go ahead at this time and discontinue the live stream, and then we will go ahead and restart it once the executive session